Thank you all. All right, so let's get started with this. So let's start with the case here again. We have a 55-year-old patient with strong family history of breast cancer who presented with a 4-centimeter node positive, triple negative grade 3 invasive ductal cancer, and this was HER2 0. Germline testing is pending. Her tumor size clinically is T2 and 1, so stage 3B, history of hypothyroidism, on Synthroid, and well-controlled hypertension on antihypertensives. So maybe I'll look at the panel and say, this is what you see a patient in clinic. How would you think about treating this patient today based on standard of care data? Maybe just a quick, what regimen would you choose would be great.
I would choose Keynote 522.
Fantastic. Dr. Matani, Dr. Reed?
I agree. I would definitely be using Keynote 522. Yeah.
Okay. So maybe Lee, you can take us through the data and tell us why do we think we should get there with Keynote 522.
So I think we talked yesterday about neoadjuvant chemotherapy in the context of HER2, and a similar development for triple negative has occurred over the last couple of decades. So typically for larger tumors, and now I think well established even before immunotherapy, for tumors of at least 2 centimeters, so a T2, even if N0, we consider neoadjuvant chemotherapy for a couple of reasons. Number one, to reduce the tumor size. Number two, to see the individual patient response. And number three, and importantly, to see if the patient achieves a pathologic complete response, and if they don't, we now use that information to determine adjuvant therapy. So that has been the standard of care for some time. We've known through thousands of patients in clinical trials that anthracyclines and taxanes together give the best response. We also know from thousands of patients in clinical trials, recently summarized by the Oxford Overview, the Early Breast Cancer Trials study group, that dose density in a meta-analysis does improve outcome for patients, particularly patients receiving who have triple negative breast cancer. And we also know from a number of trials that carboplatin in general, although there's some inconsistency of the data, improves the pathologic complete response rate, and then that leads to an improved event-free survival. And just remember that pathologic complete response rate is a surrogate endpoint, and what we would like to see ultimately is an event-free survival improvement and ultimately an overall survival improvement. So that was the standard of care until about 2 years ago when we had the Keynote 522 study, and we found that adding an immune modulator into a checkpoint inhibitor, pembrolizumab in that study, but other PD-L1s and checkpoint inhibitors have been used, improve the outcome for patients who receive neoadjuvant therapy and IO therapy. That was not a surprise because we've also known that triple negative breast cancer is the hottest, if you will, of the subtypes of breast cancer and has increased tumor infiltrating lymphocytes. A fact that actually has been known for quite some time, for decades, but really just over the last 5 to 10 years have been studied. And clearly the number of tumor infiltrating lymphocytes in a tumor independently is a prognostic sign for improving outcome to standard therapy. And so that led to the supposition that immune therapy would be active in this particular subset of breast cancer.
Thank you, Lee. Before we move on to the data that you will review, I think Dr. Barve, if you could probably comment on the role of stromal TILs and what do we think about their role in clinical practice, and should we be looking for them in pathology reports? Do we see them in pathology reports? If you could comment something about that, that would be great.
Sure. So there have been a number of studies which have uniformly shown that a number of tumor infiltrating lymphocytes do play a major prognostic role in triple negative tumors and to some extent in HER2 positive tumors. The role in ER positive tumors is far less well elucidated. So what does that mean? The more TILs we have, the greater is the prognosis, or the better is the prognosis, I should say. every 10% increase in TILs is associated with a stepwise increase in prognostic impact. Is it also related to chemotherapy? Yes, there is some data that patients who have high TILs also do better with chemotherapy. Now the problem, of course, is how do we stratify this in a uniform manner? And that's where the rubber meets the road and there are some problems. We did a meta-analysis of TILs in multiple clinical trials, and Shireen Loy was the senior author, of the first author on it, and basically showed that 30% TILs is what the cutoff is, or rather is the best cutoff for doing a dichotomization of the data. What does that mean? So if you just look at this room and say how many people are standing in this open area and not sitting at the table, the answer is 0. And that would be your 0 TILs in that particular case. If there were lots of people standing in between these tables, which could be nests of tumor cells, then there would be, if everything is occupied, it would be 100%. And so that's what we are basically estimating when we are looking at TILs. We do not calculate neutrophils and those kind of cells, but predominantly mononucleated what we call lymphocytes, but they could be monocytes, they could be lymphocytes, they could be plasma cells. So it's a little ill-defined. We don't usually report it, but it should be reported. And the problem again is the guidelines are not quite clear as to who should enforce the reporting of this, because it would be a very simple prognostic mark. And that's really one of the things that is lacking. There have been multiple attempts to do a TILs-based clinical trial, but they have not really been successful, but there are still ongoing attempts to do that.
So what we are hearing is no predictive benefit of knowing
Correct.
the TILs in terms of if we had that information, there is some prognostic impact that has been shown in data sets. We don't see that routinely in our path reports, but perhaps one day we will. So moving on to our data, Dr. Schwartzberg, you can continue.
Sure. So I mentioned that carboplatin has been tested in multiple trials, but with most of the trials showing a benefit not only in pathological complete response rate, but also event-free survival. The most recent large phase 3 trial that reported long-term outcome was the Brightness study. This study was actually looking at specifically the addition of a PARP inhibitor as well as carboplatin to neoadjuvant chemotherapy in early stage triple-negative breast cancer. So it was a 3-arm trial, and carboplatin was studied with paclitaxel in one of the arms, and then with veliparib, which is a PARP inhibitor. The veliparib really didn't contribute, but if you look at the 2 upper lines there, you see that carboplatin improved pathologic complete response rate, which we knew at the primary endpoint of the trial, but that did translate into an event-free survival benefit, which was substantial here. And so if you look at the the bottom of the hazard ratio lines, you see paclitaxel plus carbo versus paclitaxel had a 43% improvement in event-free survival, and we'll see overall survival going forward. So I think the weight of the evidence suggests that we can do better, both in terms of pathological complete response and event-free survival for high-risk triple-negative breast cancer by adding carboplatin.
Thank you. Maybe a quick rapid fire of yes and no. Did folks use carboplatin prior to the Keynote 522 data sets in their practice for patients who were treated with neoadjuvant?
I didn't use it uniformly. I used it for higher risk patients.
What about you, Reshma?
Yeah, I think given that we knew even before Keynote that the addition of carboplatin improved pathologic complete response rate, I was using it also in my higher risk patients, but there are some challenges in terms of increased toxicity, and so until we had the longer term benefits, it was a case by case basis.
What about you, Sonia?
Same. I was using it really in my younger, high-risk patients that I was trying to get a path CR.
So I think just to add this, we're not probably talking about that, but at San Antonio, there was an interesting study presented by Tata Memorial Hospital, and Dr. Sudeep Gupta presented the data set that we were looking for carboplatin for a very, very long time. They looked at patients who got neoadjuvant carboplatin and looked at the benefit of adding carboplatin to a regimen compared to a non-platinum containing regimen, did show an improvement in PCR and reported out event-free survival rates. And by age cutoff, or in younger women, both PCR and the event-free survival rates were superior in the carboplatin arm. So I think it was an interesting data set. Certainly the doses of taxane and carboplatin used were slightly different, but I think it was interesting to finally get this data that we were all hoping to get prior to the Keynote 522 and trying to offer platinums to our patients. Moving on with adding IO now to this platinum backbone.
So this really changed everything in our approach to neoadjuvant therapy in stage 2 and 3 triple negative breast cancer. The Keynote 522 study was you could call it a kitchen sink study in the sense that it had all the active drugs, including carboplatin, 24 weeks of chemotherapy, and included pembrolizumab along with the chemotherapy in the neoadjuvant setting, and then pembrolizumab to continue through a year in the adjuvant setting as well. So we learned a lot from that trial, but there were other trials, so I just wanted to show there is consistency of the data. In general, again, there's some variations depending on the chemotherapy backbone. In Keynote 522, carboplatin paclitaxel followed as a module, followed by AC, not given in dose-dense setting in that particular trial. And the first lesson was PD-L1 testing PDL was not a biomarker for improved response to pembrolizumab. It was somewhat prognostic, and if you look at the middle table there, or the graph, you'll see that most of the patients are PD-L1 positive when tested. I believe about 80% of the patients were in this study and across studies are positive prior to any therapy. But the benefit was similar in the PD-L1 positive and the PD-L1 negative group, about a 15% to 18% improvement in both groups. The overall pathologic complete response rate was higher in the PD-L1 positive, but the incremental benefit from adding pembro was similar. So we don't have to test for these patients routinely before starting them on therapy. And if you look at the overall complete response rate in the left-hand panel, you'll see it's a 14% improvement. And that is very similar to what we saw with Impassion 031, which was atezolizumab in chemo versus placebo and chemotherapy in a phase 2 trial, and about a 17% improvement in pathologic complete response there. The toxicities for the pembro arm were nausea, alopecia, and anemia, like all related to chemotherapy, of course.
So Sunil, just a brief comment perhaps. Do we have a good understanding as to why there are differences in PD-L1 expression in early stage versus late stage that makes us not to test it in the early stage setting, but in the metastatic testing, we don't offer these therapies without testing them? Maybe a brief comment on that would be helpful.
Well, that's a great question. I don't think anybody really has a good answer for that. Of course, one can postulate multiple hypotheses. One of the commonly postulated hypothesis is that the immune system is different. By the time the metastatic setting comes in, the immune system has been battered with multiple rounds of chemotherapy and multiple other agents that may have been used, and that's the reason you have to select for the ones that are high expressors. But in the early setting, the immune system is fairly robust, and so therefore it may not matter. Again, these are hypotheses that need to be proved. But simple answer is we have no idea.
Thank you. Thank you. Very helpful.
Elisa.
And then here is,
so
please.
Just 1 second, sorry,
Oh.
she had a question.
I didn't mean to interrupt.
Sorry.
No.
So just to extrapolate on that, just 1 second. So de novo metastatic, do you know anything about the value of the
Not
Can you just
really.
repeat the question for our virtual
So the
audience?
question is basically about a de novo metastatic disease. Does PD-L1 role or does PD-L1 expression play a role in determining therapy? And I don't think the answer is quite clear as of now. And if anyone has any ideas, please.
No, it's a fantastic question. So
Yeah.
we don't have any data to suggest that it might be different. So at this point, for a newly diagnosed de novo metastatic patient, we still test for PD-L1 before offering them those therapies. But it's a great question. I think it's very complex, and I'm sure Sunil will probably have a lot more to add about that, and we'll talk about that when we talk about metastatic setting. But I think there are differences between sites and expression by sites as well. So there's a whole lot of complexity that we really don't have a great grip on, but so much more to do there. Sorry, Lee, continue.
I think that's really the key, is that PD-L1 is not a particularly good biomarker for the status of the entire immune system. It's the best we have right now, and hopefully we'll have new
Additional
signatures that we can use in the future. So PCR was the first endpoint, 522, but of course we wanted to see the event-free survival, and it does translate into a clinically significant as well as statistically significant event-free survival. As you see here at interim analysis 4, there was a 7.7% improvement in event-free survival for patients who received pembrolizumab over placebo. That translated into 37% improvement. And again, you see the pathologic complete response rate on the right there. So it was a good surrogate marker, and we're awaiting still overall survival data, which takes longer. This was at 3 years of follow-up.
Right. But needless to say, this has changed our current standard of care practice, and this is what we use for our patients today who are really high risk. So more than 2 centimeter tumors, node positive tumors. Yes, you had a question.
How do you balance that, given that pembrolizumab is Q3 weekly, and the dose intensity is pretty much gone there?
Yeah, it's a great question, and of course, one trial can't answer every question. So there's so many questions about the adjuvant setting. Do we really need the AC module? There's a phase 2 study that looked at just carbo and paclitaxel, the PAC trial, which has been reported, which showed very similar results. So do we need that? In other studies that don't have the anthracyclines, there wasn't as marked a benefit. So there's still a lot to be learned, including dose density. I will say, and I'm interested in what others' experience is, when I deliver this regimen, I use carboplatin weekly, and rather than 3 weeks. I find it very hard because of the hematologic toxicity to get it in, and also tolerance. So in that module, and the AC, I think patients are pretty beat up after the first module. To do every 2-week dose dense would be a challenge after the initial module at this point.
So are you all using Q3 weekly for AC?
Yes.
Okay.
My view of it is the way that it was done on the trial was Q3 weeks, and that's the results that we got with that schedule and dose. So I think I agree with Lee that by the time patients get to the point where they're getting the AC, they've oftentimes been kind of living in the clinic because they've ended up having to come in for growth factor support and things of that sort. Plus the practical part of it, of having a patient come back 2 weeks for the AC and then 3 weeks for the Pembro, although there is a Q6 week dose of Pembro, and you can kind of match it up a little bit easier if you use that strategy. But I've been doing it the way in the trial it was
So I
done.
completely concur. I think that, we have the data and we don't know necessarily the delta of benefit that dose density has to offer, given that we're really using a kitchen sink approach. Everything that's active has been thrown at the patient for the right reasons, because we know residual disease translates into a poor prognosis. We're looking for this good outcome for our patients. We don't know what that contribution of that dose density could be, and at least the study has shown positive results with EFS as well. Having said that, I have used dose-dense regimens. I come from Memorial Sloan Kettering Cancer Center, and dose density is kind of ingrained in my head. And so I have used that with the Q6-week regimen of pembrolizumab to kind of make it easier and maybe try and finish if they're able to tolerate this really well, have not struggled with toxicities. And I don't think that there would necessarily be a downside to using that regimen that way. And so I think I have done that. And so, but a purist in me would have to follow the data from Keynote 522, which has looked at the Q3 regimen and shown equal benefits. So maybe a quick, we're talking about toxicities and we're talking about the cytopenias. Maybe just a quick 2-minute discussion in the interest of time before we move on. Any major adverse events that you faced in clinic with these patients that you want to highlight? What about immune-related toxicities given the addition of pembrolizumab? If you could do a quick 2-minute run on that, that would be great. Anyone?
Yeah, I want to say, so in general, we don't see a tremendous amount in this study. It was about 15% for special adverse events, which were immune-related, and most commonly is hypothyroidism or hypothyroidism. This patient had hypothyroidism, probably would have been excluded from the trial, but I think we're all comfortable with treating patients who have well managed. It's a very common issue, and it doesn't make sense to exclude those patients who might benefit from a life-threatening disease to get appropriate therapy. I have had one patient recently who had bullous pemphigoid type reaction and was very severe and ended up in the hospital. So it just reminded me that although it's very easy to give pembrolizumab, we still have to be careful, and we still have, especially at the low end of the stage, to make sure that their patient would really benefit to adding the therapy as opposed to. So I don't think we should treat stage 1 patients with pembrolizumab, and in part because of that.
Yeah, no, I think it's a great point that in the most common immune-related toxicity we see is hypothyroidism. We don't necessarily see the other immune toxicities very commonly, but we need to be cognizant of that and need to identify that for our patients. Adrenal cortical insufficiency. I recently had an Afro-American pregnant woman who was diagnosed with triple-negative breast cancer that I had to start in her 3rd trimester, and I did start on AC without the pembro, got her to deliver the baby, and then started the pembrolizumab. But 2 doses into the pembrolizumab, she developed what was now diagnosed as inflammatory arthritis. It was crippling arthritis for which she required a prolonged steroid taper to the point that she just never wanted to resume that back. We had a good consult with the rheumatologist and guidance of what we could do. Talking about that, Clara, maybe you can comment about what has your experience been as a surgeon when now medical oncologists are offering these therapies, and how has your preoperative, surgical testing or clearance tackled that issue?
Yeah, that's a great question, and I do implementation science as my research, so we think a lot about processes, and what the Keynote 522 regimen really changed is rethinking about the intake process for the early stage triple negative patients who would normally, we would offer surgery first. If the patient's first point of contact is a surgeon at your institution, then there may be a little bit of a rethinking process about how that intake occurs, especially because a recent publication by Dr. Elizabeth Mittendorf in the Annals of Surgical Oncology data, they looked at the Brigham Dana-Farber data and the NCDB data, and they were able to demonstrate that in T1C triple negative breast cancer patients, when they're clinically node negative with axillary ultrasound, they actually were able to detect about 10% of axillary disease, and in T2 disease, they were able to detect about 20% with axillary ultrasound, and so making them Keynote 522 eligible, if you will, when in fact they would otherwise be not. And so I think the intake process and the utilization of axillary ultrasound can be more incorporated in this type of setting. The other thing that I wanted to discuss was about the with regards to adverse events. Pembrolizumab has not been demonstrated to cause any surgical or wound healing complications, and so I do continue pembrolizumab up until the day of surgery if needed. But one of the rare complications of pembrolizumab, as just discussed, is adrenal insufficiency, which obviously would have catastrophic complications, especially with general anesthesia. Hypothyroidism similarly can have very adverse events with general anesthesia, and so those are not traditional things as surgeons we think about when we're pre-oping the patient, but definitely newer testing that we have to incorporate into our preoperative work phase.
Thank you so much. Very helpful. Yes.
So one of the things that I struggle with is we went from deciding on TC versus AC to T in somebody who's a T2 N0, and now we're throwing the kitchen sink at a 2.1, potentially at a 2.1 centimeter tumor. I like the Neopac regimen much better. I'm wondering what you all do in, you know, a 2.3 centimeter tumor when there's eligibility and you have all those concerns.
Anybody wants to address this?
It's something we struggle with all the time. I agree with you. As is typical in clinical research, we wanted to establish a new standard, and then we have to start doing the trials to back off. So in individual patients, I think you have to make that decision. And really, it's a shared decision making, just like we've talked about all weekend. You know, when there is data, however, there is data with T2N0 that subgroup did improve as well. So a patient that is inclined to potentially engender more toxicity to get more benefit, I think that's the kind of the discussion you have to have with the patient. I'm sure you do.
I agree, and I think it's maybe the direction of future trials, trying to de-escalate and see which patients may not need all this therapy, and I think that's something that we definitely need to be thinking about, because immune-related side effects are real, and they can, of course, sometimes they're permanent. So I think very, very great question.
And I guess the other question would be, in those individuals with some cardiac issues, would you ever use the Neopac on the basis of phase 2 data?
I've used Neopac. I have a patient population in Reno now that's different and very generally a lot of comorbidities that I'm seeing, and patients who are not eligible for anthracyclines, older patients. And yes, I think as long as it's data-driven, you can use other alternative therapies if you need to.
Two additional questions from the audience that are actually very, very relevant, very important. I think we should cover for the neoadjuvant space. So maybe, Sonia, if I could bother you with this question. So which patient would you not give neoadjuvant therapy? So along the lines with what was asked, and is there a role for adjuvant carboplatin therapy then? So if you could comment on that.
No, I think that's a great question. So of course the stage 1 patients, right? So the stage 1 patients, you can clearly not put them through neoadjuvant therapy, right? And of course, when we think about autoimmune disease, patients that have active autoimmune disease were not included in the Keynote trials. So these are patients that I may, of course, just do dose-dense ACT, and perhaps if they're high risk enough, would even consider incorporating a platinum agent for that specific patient population.
In the adjuvant setting, you mean?
Oh, in the adjuvant setting.
Yeah, would you use platinum in the adjuvant setting?
I don't routinely use platinum in the adjuvant setting at this point, meaning after neoadjuvant treatment.
So yes, you had somebody who did upfront surgery.
Oh, upfront surgery, yeah.
And now do you have any role for offering adjuvant platinum in the upfront setting?
I would say back to what we discussed earlier in that high-risk patient. So in that high-risk patient that I'm thinking that perhaps have a more aggressive disease, a younger patient, that's the patient that I would maybe consider using it, but that's not something that I do routinely, I would say. Yeah.
Rashma, you want to comment?
So I think there was an NRG study that was going on looking at the use of platinum in the adjuvant setting, and the eligibility was you had to have either node-positive disease, or I think it was 2 centimeters or above. As far as I'm aware, I don't think that's reported out yet. So I haven't routinely been incorporating platinum. It certainly adds toxicity.
Lee, any thoughts here?
I used to, but I think there's some negative data, and I've stopped doing it. So I would use dose-dense ACT.
Right. So I don't think the data with adjuvant platinums are robust at all, or there are no trials that have really proven a benefit for adjuvant carboplatin. And I think our practice has been, if we choose upfront surgery, we're usually now doing that only for our so-called not so high-risk patients already. I think as a multidisciplinary team of surgeons and medical oncologists and radiation oncologists, we're identifying these right patients to offer neoadjuvant therapy to when they're high risk, and then we're not necessarily thinking that they require the platinum then if they are deemed to be so-called lowish risk for these approaches. And then there was one other question about sequencing of the carboplatin and AC in this regimen. So when we think about ACT, we're using AC first and Taxol after traditionally. But many of these neoadjuvant trials use platinum first and then AC after. Is there a scientific rationale behind that? Is there any comment that somebody can make? Lee, maybe you could comment?
I think there is some older data that suggested that taxane first was better. I mean, of course, it depends a little bit on where you've trained and if you've and where you live. So we used to say there was the East Coast and West Coast in terms of the dose dense. Now there's the New York and the Houston approaches to taxane first. So in this particular case, the Houston approach won out. So I've always given ACT, but when I give Keynote 522, like we talked about, I do it as per the trial.
Right. Sunil, you're aware of any changes in the tumor microenvironment from platinum versus AC and potentially a rationale for that? Anything that?
No, I have no idea at all.
Okay. Yeah. No, I think there are some speculative thoughts about maybe the platinum taxane combination makes the tumor more conducive, and maybe that's why the anthracycline after might have a better approach. There's some data in the metastatic setting that have shown that with anthracycline regimen as well, and maybe that is one of the thought processes that could be the better way of tackling this. But I don't think that there is a strong rationale that we're aware of to do it only that way.
I mean, platinum being DNA toxic is supposed to cause greater amount of neoantigen presentation that would be stimulating the immune response.
Right.
So all that is theoretical. I don't think there's any data to support it in practical basis, at least that I am aware of.
Okay, thank you. This was great. So now this patient's genetic testing comes back. She is a BRCA1 mutation carrier. She did undergo bilateral mastectomy and node dissection. She got the Keynote 522 regimen. And pathology, despite that, now shows a T1C-N1 residual disease. 3 nodes were positive for this patient. So we are going to think about what is the best adjuvant systemic approach for her. Will we continue the pembrolizumab that she started? Would we start her on capecitabine followed by pembrolizumab? Would we start her on capecitabine and continue the pembrolizumab? Would we instead do olaparib, she's a BRCA carrier, and continue pembrolizumab? Or do capecitabine, pembrolizumab, and then give her olaparib at the back end? So any one answer picks from the panel before we go into the data? Sania, maybe, what would you do?
I would definitely include a PARP inhibitor based on the Olympia data, and I would continue pembrolizumab given that she did have residual disease. So I think I would definitely favor olaparib as well as pembro in that case.
Maybe walk us through the data as well, Sonia, on why would you continue pembrolizumab? Would you continue pembrolizumab, and where does that data come from?
Absolutely. So when we think about benefit of chemoimmunotherapy as per the Keynote 522 regimen, of course the primary endpoint looking at path-CR, but of course we also want to consider long-term outcomes such as event-free survival and distant recurrences. Like how do these patients do after long-term essentially? And what we can see here, patients that got a path-CR, it didn't seem to matter whether or not they got pembro or they got chemotherapy alone. Those patients did well, right? So I think that's reassuring. However, we saw the patients that had residual disease, as in this case, still of course had worse outcomes. But what's interesting, I think you could see here, the curves are separating. So we saw that these patients definitely had an improvement in their EFS if they received pembrolizumab if they had residual disease. So I think that's a very important point that I think we need to pay attention to. Of course, as you look on the right and you start looking on distant recurrences, we see again the benefit of giving immunotherapy up front, and I think that of course is something that tells us that not only does immunotherapy increase the chance of getting a path-CR, but does of course pans out and does have some improvement in EFS as well as distant recurrences.
Right.
Reducing the risk of distant recurrences.
The benefit, the magnitude seems to be larger in those with residual disease.
Absolutely.
But there is still some benefit seen in the PCR patients, which is interesting that patients start out, get PCR, but still benefit. And whether it's coming from the neoadjuvant portion, whether it's coming from the adjuvant portion is not something this study answered, but that's a very interesting data set. So moving on to... this study then?
So we look at the Jepar Nueva study. It's small. It's a small study that only looked at 174 patients. But what I think is interesting, this was only giving immunotherapy up front in the neoadjuvant setting, because of course I think a great deal of us are wondering, do we need to give these patients 1 year of immunotherapy? And as you can see in this study with patients that got durva and immunotherapy up front, these patients also, not only of course looking at PAT-CR, but we can see that they had improvement in invasive disease-free survival if patients got a PAT-CR. So I think this is telling us, at least, albeit that it was a small study, that even just getting upfront immunotherapy alone does improve long-term outcomes as well.
So we're not very sure.
We're not sure.
Sure at this point.
We're not sure.
Yeah, maybe this study can help us then.
So, and of course, this is an ongoing study now, the optimized PAT-CR study, which of course, these patients that have gotten a PAT-CR after upfront chemo, and of course, then we're going to be randomizing patients to either get 1 year Pembro versus Pembro for 27 weeks versus observation, and hopefully this will help us to, again, back to what you were saying, de-escalate and not give patients extended immunotherapy if it's not indicated. So I think that would be helpful. And then this study is truly looking at now the role of checkpoint inhibitors in the post-op setting after in patients who did not get neoadjuvant chemotherapy.
Oops, sorry.
That's fine. In patients that did not get upfront immunotherapy. So of course, this is not your Keynote 522 patients. So of course, this is a study, the SWOG NRG collaborative study here, looking at Pembro for patients that have a residual disease post-neoadjuvant chemotherapy alone. And I think these results, as well as that BRAVE study, will definitely be very interesting and practice-changing, hopefully, for us to answer that question that a lot of us have in clinic, especially when Keynote just came out and we had those patients in our clinic that, of course, did not get upfront immunotherapy, and you're wondering, is there a role for giving this patient now immunotherapy in the adjuvant setting?
Right. So these two trials, I guess, are answering a different question. People who did not get preoperative IO, do we want to give them in the adjuvant setting IO and see if there is a benefit if they had residual disease? Unlike Optimize that Sonia reviewed, which is for patients who achieve PCR with pre-op IO, and is there a role to continuing IO in the adjuvant setting? So very interesting trials that will help us. I guess maybe before we move on, this patient was a BRCA carrier. We thought about olaparib in this case. Do we use adjuvant capecitabine in patients with residual disease? And who would you offer that to, Reshma, in your practice, I guess?
So I think in a patient that is not a germline BRCA carrier who has residual disease, we have safety data that capecitabine in combination with Pembro is a safe combination. So I certainly would offer it in that situation. And if I could just go back for a moment and just make one comment about this adjuvant Pembro consideration. I think that, you know, it's very difficult when patients achieve a PCR and there's a lot of treatment fatigue, right? They're looking to maybe peel back in the adjuvant setting. And I think until we have the data from some of the studies that we've gone through to understand what the contribution of that adjuvant portion is, I think it's really important to follow the Keynote regimen. If you were randomized to the Pembro, whether you had a PCR or not, there wasn't a second randomization. So there was a benefit, the magnitude was small. We know the toxicities of even IO are worse when they're given in combination with chemo. The adjuvant IO alone is generally tolerated well. So I just think that's an important point to make.
Absolutely. So these trials will address those questions, but our current standard of care, as Reshma pointed out, is to continue pembrolizumab regardless of residual disease or not, given the benefit.
You know, I don't think we should say that there were 2% non-significant improvement. It shows that it was better. I mean, we have to use consistent analysis of these, and actually looking at the RCB1, there was no difference. So, and today in many trials we combine 0 and 1 because they both have good prognosis. So I think it's a completely unsettled question. That said, we only have seen event-free survival in these trials, and we know from other IO trials that the biggest benefit can be in overall survival. So we don't know yet until we see overall survival in these, so we should continue.
Yeah. Yeah, so really a lot more follow-up and a lot more research questions to be addressed. But until all of that, our standard today is what we do with the Keynote 522 regimen. And I think we're extrapolating the data that Lee's going to walk us through from CREATE-X and the safety data that we have for combining capecitabine with IO and combining olaparib with IO that we apply in this post-residual disease setting and offer it to our patients because we don't have any other tools in our toolbox to otherwise improve their outcomes. And so I think naturally we resort to what we understand and feel comfortable with. So maybe Lee, walk us through the CREATE-X, I guess.
So CREATE-X was a practice-changing trial adding capecitabine in the adjuvant setting after neoadjuvant. And this trial is interesting because it was done fully in Asia. And capecitabine metabolism in Asians is somewhat different than it is in European sets, and perhaps African Americans, we just don't know. But that said, it was a positive trial for the whole group, but most of the benefit, as you see here in the bottom right, was in the triple negative population in terms of disease-free survival and overall survival. So that led to the addition of capecitabine in the pre-IO era. I must say that I have not added capecitabine to patients getting Keynote 522 yet, although I would in a patient who would consider it in a patient who had RCB3 or perhaps RCB2 because their results are still inferior even with IO, as we just saw.
Right. And maybe tell us about the study that led to our utilization of olaparib, I guess.
So Olympia was also a practice-changing trial for patients with germline BRCA1/2 mutated HER2-negative breast cancer. The addition of olaparib for a year, the PARP inhibitor, and at 3 years you see the 8.8%, 9% improvement in invasive disease-free survival for patients who had previously received neoadjuvant or adjuvant therapy and were at high risk. So this has become a new standard. There are a number of trials that have looked at olaparib with pembrolizumab or other IO agents in the metastatic setting, so it is safe to do that.
And just summarizing this table, I guess, so I think the point we were trying to make earlier as well is that we do not necessarily have any trial that has been studied in the neoadjuvant setting that also looked at neoadjuvant platinum and at the back end looked at capecitabine or olaparib. We really do not have that data from these studies. We either have residual disease from non-platinum regimens and CREATE-X, and so for olaparib, or we have the carboplatinum in the neoadjuvant but do not have the CREATE-X or the olaparib-like regimen at the back end. But because we see poor outcomes for those patients with RCB2s and 3s and for non-PCR, we are using the comfort of these toxicities that we already are aware of, the safety data that we're aware of for these combinations, and applying that in the residual disease setting. And I think this goes back to the question again. Yes, you have another question. Yep.
I had a question there of the last two answers were offered in terms of sequencing. When we look at the olaparib, abemaciclib, people favor olaparib versus abema. So in this setting, with ongoing pembro, would you combine them? I don't think there's any safety data. How would you sequence them? Which would you continue with pembro, and would you add the other one at the end?
Could you repeat the question?
Yeah, so the question here was, in the hormone receptor positive setting, yesterday we discussed that if you have a BRCA carrier who's also 4-node positive, you would give them olaparib first, and then some of us might also at the back end consider abemaciclib if the patient is up for it and is able to tolerate it. The question here is, if you have a patient with BRCA mutation, had the Keynote 522 regimen and has residual disease, when you continue pembrolizumab, would you offer them olaparib, capecitabine, or both? Reshma, maybe you can comment?
I think I would not consider combination olaparib and capecitabine. We don't have safety data, and I can imagine that wouldn't be safe based on the toxicity profiles. I would offer olaparib, and I wouldn't sequence cape afterwards.
Sonia?
Agreed. I would definitely not be using CAPE. I would use olaparib in combination with pembro.
Lee, any different? Or
Yeah, I mean, you could either finish the pembro and then do the olaparib, or combine them. We published the Paccio study, phase 2, looking at the metastatic setting, which in terms of safety was okay.
Logistic question, you know, when the patient needs radiation, and you plan to continue olaparib
That's a good
along
question.
And pembrolizumab, I understand pembrolizumab can be given along with radiation, but do you combine olaparib or you just wait for radiation to be completed and then add it on?
So, you know, at our institution, we have a clinical trial evaluating rucaparib with RT. And so I have done that in a clinical trial setting where I've combined a PARP inhibitor with radiation. So it's an ongoing research question. Outside of a clinical trial, I feel very comfortable doing pembrolizumab as it was studied in Keynote 522 and do radiation. I do wait and then start the olaparib just because, you know, as we've discussed, I think these patients are really beat from going through so many therapies, and I think anything to do to not add on to or pile on to their fatigue or recovery from their chemotherapy is truly appreciated. It's not too much time as long as the radiation oncologists are aware that this is what we plan to do at the back end, and you know the planning is done in an appropriate time frame as well.
And for that stage 1 patient for whom you will not consider 522 regimen, and let's say if they are BRCA1 positive, would you consider PARP inhibitor like talazoparib or something?
Anybody wants to comment on that?
I would not, because those patients were not candidates for Olympia.
And that goes back to the question we were discussing yesterday briefly. I think Reshma had brought that up about MDS and AML from PARP inhibitors. And because of that potential side effect, that when the trials were designed, that was the idea kept in mind, that you want to offer these to the highest risk patient population to be able to justify a potential side effect that can be detrimental. And I think that was what, in the planning phases of this study, the thought process was. We do not have the data for this lower risk patients and the role of adjuvant olaparib, which thankfully did not show those detrimental side effects. So, but we do not have that data today to offer that. And so in practice, we're focusing on those high risk patients only.
I meant neoadjuvantly.
Neoadjuvant, there are trials that are looking at olaparib plus pembro, even a non-chemotherapy option. It's almost like what we're trying to do in the HER2 space. We're trying to optimize therapy for our patients or individualize therapies for our patients. And if there is still residual disease, maybe offer standard of care at that point. And such attempts are ongoing. We do have a study at Memorial Sloan Kettering, which is an investigator-initiated study of olaparib plus pembrolizumab that is currently being looked at. And there are other trials also evaluating such efforts.
Well, there was a study that was presented, I believe, a year or two ago out of MD Anderson.
From MD Anderson,
but I
right.
wasn't sure if anybody was using.
That has not changed our current standard of care. It still remains to be a research question that we're still trying to address. Would the panel like to agree or?
Great.
Okay. So I think we touched upon these first two questions. I think you brought up that question about a 2.3 centimeter node negative tumor, and Lee, as appropriately pointed out, the theme has been it's a patient-physician shared decision-making process, and we have to individualize and discuss side effects and the data that the way it stands, and make those conversations with our patients. Maybe a quick answer on is the approach any different for ER less than 10% tumors, or ER 10% tumors, I guess, and higher tumors with Keynote 522? What would you do?
In ER low, and it depends on your pathologist. So if they're reading weak ER staining 5%, I consider them negative in my current setting.
So Neil, any comments from a pathologist view?
Yeah, so the ER cutoff of 1% was developed based on some of our data from Oncotype DX comparison, so the E2197 data, where we showed that the concordance between the local IHC, central IHC, and RT-PCR ER values and PR values were the best using 1% cutoff. And the idea there was, if we peg it as low as possible, the clinicians have an opportunity to try endocrine therapy in these particular patients. Now, whether the biological cutoff is 1% or 10%, we have been having these continuous disputes for as long as I can remember, and really there is no clear answer. The low ER patients tend to behave more like basal-like or triple-negative tumors. But again, is there an additional option, I should say, for treating with endocrine therapy or considering endocrine therapy? Sure, that's an additional option that is there. If you choose to exercise it, go ahead. If you don't, that's fine. but you have been given that option, and it's on the table. It's really the patient and the oncologist's decisions rather than us as pathologists making those kind of decisions.
Lee,
There
can
are
make a quick
two
comment.
additional pieces of evidence that suggest that they're not as sensitive. I mean, if you go back to the old OLRED, low OLRED 2 or 3, low intensity, low percentage, they didn't respond. Or
Not,
2 or
not
3.
really. The Harvey paper that you're talking about from JCO from 2003-ish, from which the ULRED score was developed, it has several problems. But in spite of that, greater than 2 showed response. The second part of it is the ULRED score and the entire analysis was developed in what we would consider awful manner today, because all of these tissues were frozen, and that was the standard of care for doing ligand banding assay. The leftover tissue from the frozen bits were converted to paraffin into a microarray, and then the analysis was done. Nobody in their right mind today would do these kind of pre-analytic variables for ER analysis. So there are complex issues here, whether we can extrapolate the data from one DeFi antibody, which is completely different from what the antibodies we use, the SP1 or the EP1 antibodies today, which show greater degree of sensitivity. So there are lots of kind of weeds around that we need to clear.
I agree, that's old data, but new data is if you look at ER positive and do intrinsic subtyping, there are a group that are basal.
Right.
And definitely the basal group is enriched in those that have ER low.
Yeah.
So we have to.
I have no idea what basal means.
Right.
I do not really believe Chuck Peru's data. I know this is really getting into the real weeds and real controversial stuff.
Sounds like we need a
That's good.
We need to stop here.
separate debate session, a separate panel discussion
exactly.
on this topic,
So-
which clearly is not going to be resolved today.
Yes, exactly.
But needless to say, at this point, we do not have all the tools to be able to make a very definitive, homogeneous decision about how we would deal with this. I think many of us would probably do the Keynote 522 regimen and still offer endocrine therapy at the back end as well to a patient. But again, a gray area, something that we really need to sort out for this low ER positive tumors and understand them.
So one quick
better.
comment, the Ingrid Meyer's trial failed to show that there was any significant impact of triple negative versus basal-like.
Right.
So that's an important negative trial, and it was turned down because of futility.
For
rather,
platinum.
Exactly.
For platinum in the basal-like tumor. So yeah, a lot more to learn about triple negative, which is not really one simple subtype, as you can tell. I think in the interest of time, I need to move on, and maybe we'll hold on to the questions for later.
I have not asked one question.
Yes, sure.
I think it's really forward, really important to get a straightforward answer from the panelists. Very common in practice. In which population of patients BRCA negative do they add capecitabine to Pembro versus following Keynote 522? When do you add capecitabine to BRCA negative patients?
In patients with residual disease.
Anybody you
Yes,
combine
yes.
it.
In any patient that has residual disease, we know that the presence of residual disease is a poor prognostic sign. And in fact, there are additional studies that we're going to go through that are looking to address other strategies. You know, at Miami Cancer Institute, we're about to open the Persevere study, which is looking at genomically directed therapies based on the additional analyses that are done on the residual disease. And there are other strategies that are being investigated because we know that that patient population is at high risk for recurrence.
Because in real world, I think once we started using the adjuvant Pembro, not everybody continued using capecitabine.
Right. The Keynote 522 did not provide that data set, so you're absolutely correct. I don't think we all homogeneously practice that because there's just no data for that. Having said that, what the panel was trying to say is, given that we have independent data from CREATE-X, which is what we used for our patients before Keynote 522, and we have data from the metastatic setting that there is safety for combining capecitabine with pembrolizumab, and we feel comfortable that we're not harming our patient, maybe potentially helping because we know that no PCR translates into a bad outcome for these patients. We do offer them in our practices. This is our individual opinions about that. This is not supported by level of evidence that can be considered very strong on any guideline, but this is what we all do.
Clinical clinical trial is always the right answer.
Clinical trial is the right answer. So if you have a trial that is applicable to your patient with residual disease, I would absolutely choose that because this is really an important question to address. So moving forward, this patient had 1.5 years after completing their adjuvant therapy. So they completed olaparib and pembrolizumab and now has a new cough and staging scans that revealed pulmonary nodules, and biopsy from this confirms that ER is 0, PR is 0, HER2 is negative but it's 1+, AR is 0, and PD-L1 is positive with a composite positive score of 10. So maybe, Sunil, you can tell us a little bit about the PD-L1 expression. We touched upon this, but maybe if you could walk us through, that'd be great.
Sure. So thanks. PD-L1, the basic role of PD-L1 is to control inflammation. So that this normal pathway by which the body shuts down inflammation is hijacked by the tumor to prevent immune-related cell death or tumor cell death. And basically, we have this checkpoint inhibitor. Now we are trying to inhibit it, and so we are trying to see which of the tumors have overexpression of PD-L1. The problem, of course, is there are multiple antibodies, each of which recognize different domains. The scoring systems are different. Some include only the tumor cells, some include only the immune cells, and then some scoring systems include both the components. And that's really where a lot of the problems arise, because many a times scoring these clumps of cells, particularly small immune cells, which sometimes stain very strongly positive, to realize how many cells there are is quite difficult. So that's one part of it. The second part, of course, is depending upon the drug, it might be a companion diagnosis or a complementary diagnostic assay. The cutoff points can vary depending upon the agent being used. Again, a lot of these phenomenal differences in the assay conditions. The next part and the last bullet point on this slide is the intratumoral heterogeneity. And that really is a huge problem in terms of PD-L1. So you have these clusters of positivity that are scattered sometimes in a sea of negativity. So small islands of positivity can be present quite often, and so you really have to score the entire slide rather than looking at small patches. And therefore, there may be differences between a biopsy and an excision specimen where we have a larger amount of tumor to see. And it can work in both places, both ways, that because you have a biopsy which has an island of positive cells, you'll call it positive for CPS. And then you have an excision specimen which is a larger amount of tumor, and that small amount of island does not anymore count to the percentage of positive cells, and that really becomes a problem. And this particular slide illustrates the commonly used antibodies. 22C3 is the most commonly used antibody, and that's associated with the drug pembrolizumab. But there are multiple other antibodies that have been used. The more commonly was the SP142, which was the Genentech antibody. And the problem, again, as you can see, the cutoffs are so different, ranging from 1 to 50% for tumor percentage positivity, and for CPS or combined positive score, it can be greater than 1 or greater than 10. Again, you are scoring not only the tumor cells when you're looking at CPS, that is percentage of positive tumor cells plus lymphocytes plus macrophages, but we don't include plasma cells. And those kind of difficulties in recognizing which cells are there in the microenvironment, what is the degree of expression, is quite difficult, and that requires a certain degree of training before you can do it consistently. So PD-L1 scoring is not easy.
So maybe Sonia, you could walk us through what you would do for this patient and why.
Yes, absolutely. So this, I guess I'll just kind of remind everyone the first trial we had that gave us some glimmer of hope for these patients with metastatic triple-negative breast cancer was Impassion 130, which was combining atezolizumab with nab-paclitaxel. And I think, of course, a lot of us had started using it, and then because of the accelerated FDA approval, but then came Impassion 131 that used atezo plus paclitaxel, and what we saw was that they did not meet their primary endpoints, and the FDA withdrew that approval. Then we now have Keynote 355, which essentially is combining pembrolizumab with chemotherapy, either taxane-based or carbogem. And of course, the PD-L1 assay, kind of piggybacking off what Sunil just said, used the CPS instead of the Ventana. CPS score over greater than or equal to 10 was used as the patients that seem to have the greatest benefit. And of course, now has really changed our practice, where for patients that are metastatic triple negative and has a PD-L1 positive tumor, we're now offering immunotherapy plus chemotherapy for these patients, given the improvement in the median PFS as well as the OS data that was encouraging. So when we look here, just to go over the data briefly, we see here in Keynote 355, these were patients that were previously untreated, locally recurrent or metastatic triple-negative breast cancer. Patients were randomized 2-to-1 to either receive Pembra plus chemotherapy or placebo plus chemotherapy, where of course we were looking at PFS as the primary endpoint. Go to the next slide. And what we see here in the CPS greater than or equal to 10 or PD-L1 positive patients, we can see here the improvement in PFS with a hazard ratio, it's a little hard to see here, but about 0.65, where there was an improvement from 5.6 months to 9.7 months in these patients. And of course, the subgroup analysis, I think, was very interesting in this ITT group, because what you will see here is that taxane, patients that received taxane as their chemotherapy backbone did seem to derive better benefit, especially the patients that got paclitaxel. These patients seem to have the best outcome, and I think a lot of us are using a taxane-based regimen in combination with immunotherapy instead of the carbogem. And then, of course, we saw the OS data presented at ESMO in 2021, which, of course, looked at patients that, again, in this PD-L1 positive group, and we again saw an improvement in the overall survival in these patients from 16.1 months to 23 months. So again, very encouraging data, and I think it's hard to argue against in our patients that are PD-L1 positive. So of course, we know, we discussed this earlier, so I won't spend too much time here, but of course, giving immunotherapy doesn't come without side effects. So of course, when we look at Keynote 355, the most common side effect was hypothyroidism, but most of these were grade 1 or 2. It was very rare grade 3 side effects, so very encouraging data as well. And then this study here, of course, looking at KeyLink 009, which was a phase 2/3 randomized trial of Pembro plus olaparib versus Pembro plus chemo after induction first line, is ongoing, and I think this will answer a lot of our questions, trying to really understand the role of combining this, of course, not only in the BRCA mutated patients, because this is an all-comer study, of course, a stratifying factor. We'll be looking at patients that are BRCA mutated versus wild type to see what that differentiator would be, but I think these studies are going to really be help us understand how we can sequence, how we can utilize some of these other targeted therapies that we now have.
So maybe quickly, I guess, if this patient was PD-L1 negative, how would you treat this patient? And if this patient we know is BRCA mutant and was PD-L1 positive, which it is, how are you thinking about the data for applying that in the first-line metastatic setting? Maybe Sonia, you could answer just what would you do and why?
Yeah, so in this so the patient is PD-L1 negative. I think, of course, what we tend to go for would be single agent chemotherapy. Of course, this patient being BRCA mutated, then we start thinking about how early would we want to introduce a PARP inhibitor in this patient, of course, because we know the Olympia data did show the improvement in survival, although not significant OS survival data. We didn't seem to, that did not seem to pan out as well. But again, using this algorithm here, just to remind everyone, for PD-L1 positive patients up front, we are using Pembra plus chemotherapy, and then for the PD-L1 negative patients, single agent chemotherapy sequentially has still been what NCCN recommends.
Reshma, would you do a PARP inhibitor, or would you do the Keynote 355 in this particular case?
You know, we talk a lot about this. I haven't seen a patient like this in my practice yet, but I would say that if I had the opportunity to use both, given the survival advantage that we saw with the use of immunotherapy, my sequence would probably be to do the immunotherapy and chemo in combination first line and save the PARP for after.
I concur with both of your comments. Haven't seen such a patient, thankfully, but I had to really struggle with that. But if I had to, I would choose the IO option. So this patient did get the IO option with chemotherapy, and unfortunately 4 months later did progress in the lung and the liver. And what would you treat her next with? Maybe, Reshma, if you could give me one answer if comes to mind.
Was this patient BRCA, or she was not BRCA? I've lost
So
track.
she is BRCA carrier. She did have olaparib in the adjuvant setting for a year. And then she recurred and had metastatic disease, and we gave her a PD-L1 positive tumor.
So I think in this situation, second line, I would be considering sacituzumab.
Yes. And so she is HER2 low, yes.
Right, and
so,
that's a good point.
So you're trying to make a point about should we use sacituzumab or would we use trastuzumab deruxtecan based on the DESTINY-04 data. I think we heard from Dr. Michele this morning all the data on the ASCENT trial, so I'm not going to have our panel go through that data again, but needless to say, we saw a statistically significant improvement in both progression-free survival and doubling of overall survival in this metastatic patient population that received sacituzumab in this large phase 3 randomized trial. And that doubling of OS is something that we had not seen before. So it was really something we were very excited about because we see OS in the first line for PD-L1 positive, and we have OS with sacituzumab. And the data that you're referring to, just a quick comment, I think we heard about neutropenia and diarrhea being the most common side effects, but the data you were referring to from trastuzumab deruxtecan comes in from the exploratory analysis of the DESTINY-04 that had 58 patients with ER-negative, HER2-low breast cancer. It certainly got the label for all patient comers, including those 58 patients. The way I sometimes think about it is we have a level 1 evidence from a large phase 3 randomized trial with sacituzumab. Am I ready to give that up, given that we're so excited about trastuzumab deruxtecan, which I believe is a great, great drug, certainly has its benefits. I have not necessarily changed my practice, at least. Would be curious to see if the panel agrees or disagrees.
No, I absolutely agree. I think for triple negative patients, I'm using SAST first, and then, of course, we don't know how to even sequence ADCs, right? But that's my preference, given the small number of patients on DESTINY-04 that had
right. Lee, would you do the same, or?
Yeah, I agree. And the number of patients who are HER2 low in triple negative is a lower percentage. So.
Yeah. We're also trying to evaluate the role of pembro versus no pembro, even in PD-L1 in the first line setting with sacituzumab. This is an ongoing study, and sacituzumab is also being evaluated in the SASIA trial for those patients who have residual disease. So I think these are interesting trials to try and see what more can we get out of. This is the data we were referring to for the exploratory analyses in the ER-negative, HER2-low in 58 patients. Certainly very impressive data set, and I'm sure that we might have probably more to offer for our patients. I think it's going to get even more complicated now that we have another TROP2 ADC, the datopotamab deruxtecan, so similar payload as trastuzumab deruxtecan, but TROP2-directed ADC. We've seen updated data at for triple-negative cohorts, overall response rate of about 32%, and in those who had not received prior deruxtecan or sacituzumab, 44%. And so this study is ongoing currently, the TROPION-02 trial that is being focused on PD-L1 negative tumors that are untreated, so first-line datopotamab trial. So we'll see how this whole treatment paradigm completely evolves. But today in clinic, this is how we're thinking about them. Newly diagnosed HR-negative, HER2-negative breast cancer, if they're PD-L1 positive, we're offering them pembrolizumab. If they're PD-L1 negative, we're giving them chemotherapy. In the second-line setting based on the ASCENT, we're thinking about sacituzumab. Certainly, we don't have any sequencing data. We don't know what is the right approach. But at least for now, for HER2-low, trastuzumab deruxtecan is an option, and we can offer that. Even I'm giving them after sacituzumab at this point. Yeah. For our drumline BRCA patients, we do have PARP inhibitor as an option. For our MSI high or high tumor mutational burden on NGS assays, also we have data to support pembrolizumab for those patients. Thank you all for your attention.